Welcome to Endocrine Uncovered, where Dr. G, a board-certified endocrinologist, Tanya and Stacy, nurse practitioners with a knack for making hormones make sense, squash hormone myths, and answer the questions your Google search history is too embarrassed to admit. Welcome to Endocrine Uncovered.
Hi, y'all. I'm excited to be back for another episode. I'm Tanya. I'm a nurse practitioner in endocrinology.
Hi, I'm Dr. G, endocrinologist and hormone detective.
And I'm Stacy, nurse practitioner, co-host to answer all your questions you've been thinking about. Today we're going to talk about what happens when your thyroid goes into overdrive. So a term we call hyperthyroidism.
Ooh. Okay, let's start. Before we jump into the science, let me give you a quick case study.
Okay.
Because this is how hyperthyroidism often shows up. So we have Sarah. She's a 34-year-old woman who comes in feeling anxious, having heart palpitations, trouble sleeping, has some unintentional weight loss. Interestingly enough, she's currently 8 weeks postpartum. She's been told that it's just stress of being a new parent. A lot of it is postpartum changes. Maybe she's having too much caffeine. And she's also noticing some heat intolerances. She's feeling shaky, and her periods are irregular. She got some labs done, and her TSH is suppressed. Her other thyroid hormones are elevated, and she's been told that she has hyperthyroidism. So, what do you all think is going on?
Okay, so first off, when the TSH is suppressed, TSH comes from the pituitary gland, which is in your brain, and it goes low because it's not wanting to stimulate more thyroid production. So when your thyroid gland, which is a little bow tie that sits in your neck, is overproducing thyroid hormone, the TSH, which comes from their brain, is going to drop very, very low because it's not wanting to stimulate the thyroid to make more hormone. So when we say the TSH is suppressed, that's what we're referring to, is that there's too much thyroid hormone production. And thyroid hormone production could be T4 and or T3. The thyroid gland makes predominantly T4, but interestingly, there are conditions where the thyroid gland will actually make more T3. And Stacy, you're up.
But Tanya's supposed to tell me what I'm supposed to answer
Oh, okay.
next.
Okay.
Okay,
Okay.
sorry, Taya. I haven't presented a case in a while.
Well,
What do you
I
think
mean,
about the symptoms? So she's having weight loss,
Yeah.
with the heart
mhm,
palpitation,
mhm.
feels anxious, her periods are irregular, but keeping in mind she's also 8 weeks postpartum.
Sure.
Yeah.
So one of the first questions you asked was, what do you think's going on?
Mm-hmm.
I I tell my colleagues one of my favorite conditions to treat is hyperthyroidism
Mm.
because it's very, when you really think about it, despite the fact that people feel horrible. So people who have been hypothyroid say this is like, I don't feel good. And then if they've ever experienced both where they felt hyperthyroid, they almost always say that was worse.
Mm-hmm.
And but the reason why hyperthyroidism to me is really simple is that there's three reasons, and we'll talk about those later, but there's really only three reasons why someone is hyperthyroid generally, right? And the symptoms are kind of interesting because they vary from person to person. There's like the classic ones that you read about in the textbooks,
Mm-hmm.
and then there's the real life ones that sometimes we see that are sometimes outside of the textbook. So the classic symptoms of hyperthyroid are everything internally is going really fast, right? So your heart's beating faster, your gut is moving faster, your brain, your body's trying to kind of keep up with whatever is going on. And so some people just say they feel like really jittery or just like they're just really revved
Mhm.
up all the time. They may not have diarrhea, but they have like more frequent bowel movements. And then they feel warmer, their brain just isn't sort of keeping up with this. And some people are really tired because depending on their age, kind of keeping up with that internal overdrive can be exhausting. Not to mention the fact that you may not be sleeping very well because everything is go, go, go so you're just not getting that like peaceful, restful sleep. Um, the textbooks always say weight loss, and we do see that in really extreme cases of hyperthyroidism, but I've actually seen a lot of people gain weight when they're hyperthyroid because they're hungry and they're feeding their hunger constantly too,
Mhm.
maybe that more like mild hyperthyroidism.
Mhm.
Mm-hmm.
And then periods are interesting because, okay, she's 8 weeks postpartum, so we can't exactly say like periods should
Yeah.
be normal yet, depending on like is she breastfeeding and what were her periods like before, etc. But in someone who had been having normal periods, sometimes they'll start to have more frequent but very light periods too.
Mm-hmm.
So those are kind of like your like classic, but then at the same time, some of these
Mhm.
other things that there's kind of some random other ones out there too.
I'm going to take you by guys back 20, 25 years. Whenever I was rotating through the hospital with my beloved mentor, Dr. Chip Ridgway, who is a
Oh,
phenomenal endocrinologist, and we were seeing a hyperthyroid patient in the hospital, and I was so struck by his ability to understand the uh, symptoms of hyperthyroidism. And so one of the things is he's like, okay, so do you eat breakfast in the morning before you go to work? Oh, yeah. And then what happens on your way to work? Oh, I stop and get donuts. And then what happens when you get to work? Oh, I eat egg McMuffins when I get there. And then have you gained any weight? No. So these people are losing weight and eating an excessive amount, which will come up to later is how people don't gain weight at later, but they are eating a lot of food and not gaining weight. There
Mm-hmm.
might be other things where they're finding that they're what we call hyperdefecation. He would be like, "How many bowel movements you're having a day?" And I'm like, "Why is he asking that?" But it's because when you're hyperthyroid, you're having a lot of bowel movements every day. Like people will be having 5 bowel movements a day. It's not diarrhea, but
hmm
it's just they're having a lot of bowel
there's
movements.
everything's just moving faster.
Everything's moving
Mm-hmm.
faster. They're hot, they're irritated, they're agitated. And like when Graves' disease was first diagnosed, it was diagnosed in a mental institution because these patients thought they were losing their mind. They were so anxious and so irritable and they thought they were something was wrong with them, but actually this was just their hyperthyroidism. And
Mm-hmm.
so it's like people who are hyperthyroid feel like they're like really hyperthyroid, not subclinical hyperthyroid, but overtly hyperthyroid. They do not feel well.
hmm
Mm-hmm.
And for those of you that are wondering, so Graves' disease is a form of hyperthyroidism. It's probably the more common form that we
Mhm,
see. It's an autoimmune form where immune system starts attacking the thyroid and makes the thyroid oversecrete
mhm,
thyroid hormone.
mhm.
So
So,
for this patient, how would you distinguish if this hyperthyroidism is a temporary sort of hyperthyroidism after delivery or after a pregnancy postpartum versus Graves' disease, which you said is an autoimmune
yeah,
form of
yeah. We should
hyperthyroid?
probably talk about the types of hyperthyroidism. Do we want to take turns? We start with Stacy and then Tanya, and
Yeah,
then I'll
yeah.
finish up. Okay, go ahead, Stacy.
Okay, so I'll start with Graves since that's the one I started to talk about. So
Mhm,
Graves is autoimmune. Immune system makes an antibody. There's two different antibodies that we're aware exist in the body. One is called TSI, thyroid stimulating immunoglobulin, and the other one we call TRAB, thyroid receptor antibody. These are antibodies that come tell the thyroid to make more T4 and T3,
It's
or
like the
convert
foot
to
on the gas
T3.
pedal, isn't it, Stacy? It's like, woo, it's just making that
Yeah,
thyroid
just like
abundance.
hit
Yeah.
the ground running. Let's just
Yeah.
okay,
Yeah.
and then it can cause all those symptoms. Um, and we see this more commonly in females. It's about 5 to 1 female to male ratio. It's definitely genetic, so we see this running in families. It may not be that someone had Graves' disease in their family. Maybe they just have autoimmune thyroid disease. So they also may have a family history of Hashimoto's, which is a common form of autoimmune
Mhm.
hypothyroidism. Um, but we can distinguish that in a couple of ways. One, we can check the antibodies and see if they exist in that person, and if they do have those positive antibodies, we can not definitively, but for the most part, say yes, this looks like Graves' disease. There is another option where we can do what's called a thyroid uptake scan. They swallow a pill of iodine that's got a special isotope attached to it that when we take a picture of your thyroid gland several hours later, it'll tell me if your thyroid took up iodine. Iodine is what the only organ in your body that needs iodine is your thyroid. And so the thyroid takes up that iodine, and if it's taking up a lot of iodine, that means it's overactive. It's needing a lot of iodine to keep it needs a lot of fuel to keep the gas pedal going, right?
Hmm.
So we can do a picture to see, does it look like your gland is taking up all this iodine, and that is more consistent with Graves' disease. Anything else I should say about Graves?
Treatment, maybe.
Well, we'll get to
Mhm.
treatment eventually, but yeah, just as far as like causes right now.
Okay, okay.
Mhm.
Okay,
All right.
okay.
Talk to you.
I think that's good. And then the other thing that I think about, especially for someone is who's postpartum, is this thyroiditis, right? So that's
Hmm.
kind of a fancy way of saying that your thyroid gland is very angry at you. It's very inflamed, and this is oftentimes temporary. We see this with, after pregnancy. We see this for after a viral cause, right?
Hmm.
Oftentimes. And as far as I'm concerned, really unclear why this happens in certain people. But it does resolve over time, right? So it's not an autoimmune process, but it is an inflammatory process where the thyroid gland is angry. It's producing a lot of the T4 and T3 hormones. So you get some of the same side effects or that you have with Graves' disease. And it develops usually within that first year after childbirth.
Yeah.
And sometimes it can be induced by different types of medications as well. So I like to do a thorough medication history from patients too. So sometimes I think
Mhm.
about medications like lithium or amiodarone to think about some of that.
Yeah.
This wasn't the case with
Amiodarone.
this
Hmm.
patient.
Hmm.
Yeah. And it is acute. So, and oftentimes you want to be careful with treating these patients because sometimes if you treat them too aggressively, then they really bounce back the other side of the spectrum.
Yeah.
Yes. Yeah.
Yeah, so to distinguish Graves' disease tends to last. It's funny, when we first started practicing, we used to think of it as about a year long, maybe 18-month kind of disease, and now we think of it as more of a 2 to 3 year
Mm-hmm.
process with Graves' disease, and in some people it could be much longer than that.
Hmm.
But we got burned by stopping treatment too soon in our former Graves
Yeah.
patients, and now we know you gotta keep treating them a little bit
Yeah.
longer because
Yeah.
sometimes it comes back. Yeah,
Mhm.
versus a
Yeah.
thyroiditis, short term, six
Mhm.
six weeks,
Hmm.
Mhm.
generally of the hyper phase, and then could be followed by a hypo phase or just coming
Mhm.
back to kind of a normal thyroid
Yeah.
function. So,
Yeah.
Mhm.
Yeah.
And then other causes, Dr. G, of hyperthyroidism.
Yeah. So you could also have a toxic nodule, meaning there's a nodule in there that has a mind of its own. This making thyroid hormone despite what the brain pituitary gland is telling it to do. And those nodules are going to continue to make thyroid hormone. And it's interesting though, because people with toxic nodules, their TSH will be low. Their T4 may be normal, but their T3 will be elevated. But interesting, they don't have a lot of the symptoms associated with hyperthyroidism. They may not have weight loss. In fact, a lot of these patients have a little weight gain because it stimulates the appetite. They might feel anxious. They might have higher blood pressure, higher heart rate, but the symptoms are a little bit different than what we see with hyperthyroid Graves patients, where it's a little bit more subtle and a little less defined.
hmm.
And so those patients, when we see, we can evaluate that with doing a thyroid scan and uptake, which will the iodine, as Stacey was saying, the iodine in Graves' disease will be high uptake and thyroiditis will be really low uptake. But in a nodule, all that uptake will go to that one spot, one wherever that thyroid is, the right lobe or left lobe or wherever that's at.
Hmm.
So that's one cause. And then the other thing that I think is really important to recognize is over replacement of iodine. And that's certainly very common because we're seeing that people are seeking out naturopathic or they're going to looking for functional medicines that may be like, hey, I'm feeling tired, and they're hearing that it might be their thyroid, so let me give you some extra iodine. Well, iodine is what feeds the thyroid gland, and iodine is what turns into our T4 and then T3 of our thyroid hormone production. And so people who are taking too much iodine can actually become hyperthyroid. And interestingly enough, people taking extra iodine do not lose weight, they tend to gain weight. And so you
Mhm.
have to be really careful. Iodine is in many sources, so you could take it as a supplement. I will tell you a very interesting story. A 42-year-old woman came to see me because her TSH was suppressed, her T4 was elevated, and she was extremely anxious. And if you could see me on
YouTube.
YouTube, you see this is what's happening to the fingers. They're very shaky.
Mhm.
Um, and what was happening is that she was actually getting the Costco seaweed chips, and she was consuming them a lot. All
Mhm.
that iodine in that seaweed was causing her to become very hyperthyroid.
Mhm.
So we have to think about all the iodine we're putting in us. Iodine comes from seaweed, it comes from kelp. And you could have iodine because you've had a CT scan with iodine. You could be taking too much iodine in a supplement. All those are things to consider. And then finally, we cannot forget over replacement of thyroid hormone.
Hmm.
If you do not make thyroid hormone or you're overtaking thyroid hormone, it's going to make you hyperthyroid.
Yeah.
Yeah, I will say feeling fatigued and just taking thyroid hormone for that, not a good idea.
Not a good
And
idea.
oftentimes you're going to feel even more tired
Yeah,
when you're
yeah,
over
yeah,
replaced.
Yeah.
yeah.
People talk about that fatigue. It's tiring to keep up with that increased metabolic
Hmm.
demand. And
I
it's
know.
a different kind of fatigue, but people are tired.
I know.
Hmm.
In the 1970s, like I was born in the 1970s, and there was a study back then looking at giving people thyroid hormone for weight loss. And
Hmm.
all those patients gained weight. So
Hmm.
you don't take thyroid hormone if you don't need it.
Mm-mm.
Hmm.
Mm-mm.
Yeah.
So just to recap for this patient, where would you start in terms of testing? What labs would you draw?
So we're gonna repeat her labs. We're also gonna ask her questions about is she still taking her prenatal or her postnatal, and does it have biotin in it? Because biotin can
Mhm.
interfere with our lab assays, and so we want to make sure we get an accurate result. We want to ask her about biotin in general, just in her supplements or in her food. We're going
Mhm.
to repeat those labs just
But
in
ask her
case there
about
was
collagen too.
collagen as well. Collagen may
Yeah.
interfere as well. Um, and make sure that we're getting accurate labs. We're going to check our antibodies to see if they exist. We're actually going to check antibodies for hypothyroidism too, even though she's not technically hypo
Yeah.
right now, because what if this is a whole nother Oprah, but Hashimoto's hypothyroidism, whole nother podcast, I should say, where
Mhm.
she's actually having a temporary thyroiditis,
Yeah.
temporary hyperthyroid state. Give her another month or two, and she's going to suddenly be
That's
hypo,
right.
right?
Very good
So we're going
point.
to check those
Yeah.
antibodies for Hashimoto's too. See season one episode on
Mhm.
hypothyroidism, and then if she's breastfeeding, I'm going to give her the option if she wants to do an uptake scan or not. A
Mhm.
lot of times in these women that are postpartum, and particularly if they're breastfeeding, they don't want to have to pump and dump because of the iodine that they're going to have to consume for this test. If they have antibodies and it's positive, we're going to say this looks like it's going to be a Graves' disease. We may do an ultrasound of her gland. You can really gain a lot of information from this. You can see if it looks like there's a lot of blood flow to the gland, if it's enlarged. I'm going to do an exam on her thyroid and actually feel what it feels like. The endocrine trained provider can probably tell you the difference between a Graves gland and a Hashimoto's, a hypothyroid gland versus maybe fill a nodule. And so Graves thyroid glands feel different. They're bigger and they're juicier and they're thicker and
Yeah.
you can just kind of
They're
tell.
hot. They're really hot.
Yeah. Uh-huh.
You
Uh-huh. They're
feel. Yeah.
warm. Yeah. So maybe an ultrasound doing the
Yeah.
exam, but honestly, if she's still hyperthyroid and she has the antibodies for Graves, I'm going to say this is Graves. And then
Yeah.
likely in this
Yeah.
age of an individual, those
Hmm.
those thyroid nodules that are overactive, those are more like we see those a little bit more in our older patients,
Yeah.
not so commonly in our younger
Hmm.
patients.
Hmm.
Mhm.
Yeah. So do we need to do a thyroid scan and uptake with their nuclear medicine if we have someone who has Graves antibodies that are positive? Can we forgo those and just treat them as Graves?
I would treat him as Graves.
I would too. I would
Mhm.
too.
Mhm.
Yeah. Yeah. Okay. So should we talk about treatment?
Mhm.
Mhm.
So,
Yeah.
what are our treatment options? Let's talk about symptom control first. So, what
Yeah.
is kind of um, What is your
Mhm.
take on symptom control in terms of just an acute kind of helping this person out?
Yeah. So the most immediate thing that's going to help, like bring down their heart rate and bring down their anxiety, is going to be beta blockers. So
Mm-hmm.
beta blockers, and oftentimes propranolol is used or atenolol, depending what their blood pressure is. But propranolol is that medication that a lot of people who are like going to go up on stage or going to give a speech, they might take a little dose of propranolol before they get up there to like calm them down. Well, that can be used for Graves patients to kind of calm things down. If they have a high blood pressure, then I would put them on more of a blood pressure beta blocker instead of
Mm-hmm.
propranolol. I'd put them on something like atenolol
Mm-hmm.
or metoprolol.
Mm-hmm.
Mhm.
Yeah,
And
and
it just slows the heart rate down,
Yep.
and
that's
it might help them sleep a little bit. And but
Yeah.
sometimes we talk about sleep aids as well if they're having a really
Yeah.
hard time sleeping.
Yeah.
mm-hmm.
Yeah.
And then I talk to them about, high heart rate is a real concern right now in this acute
Mhm.
phase. So
Mhm.
really staying away from activities is, I think it's the only
Yeah.
time I tell people not to really exercise and get their heart rate up because their
Right.
heart rate is
Right.
resting heart rate is already so high until they can improve their symptoms a little bit better and, avoiding hot saunas and things like that.
The other thing that I think is important in these early phases when they're still hyperthyroid before they start to reverse to a more normal thyroid function is the risk of clotting when you're hyperthyroid. So
Mhm.
if I have a woman who comes in who's on oral contraceptives, I'm going to stop those oral contraceptives because oral contraceptives on their own carry a risk of blood clots. So if I
Mhm.
have a hyperthyroid individual who's on birth control, I'm going to want to hold that until I start to reverse their thyroid function so they're no longer hyperthyroid and then they can restart it.
Mhm. And then, Stacey, what thyroid medications or anti-thyroid medications
Hmm.
do you use?
So we have used the same anti-thyroid medications since the 1950s, something like that. It's actually slightly appalling, but interesting and impressive that we still are using the same drugs.
Mhm.
These are not drugs that stop immune system from. So if somebody has a nodule that's over secreting, that's a different story. We'll talk about that. But if we're talking about someone who has Graves' disease, okay, we can use a what we call an anti-thyroid medicine. It doesn't stop immune system from attacking. We're basically going in and trying to kind of stop the thyroid from overproducing and just saying a hope and a prayer on the immune system that eventually that's going to kind of calm down. Okay, and we know 2 to 3 years, give it, and oftentimes it will calm down. So we do these medicines called anti-thyroid drugs. And Tapazole was the brand name, and we all call it methimazole now, but way back in the day it was called Tapazole. That's one medication. The other one is called propylthiouracil, and it's much easier when you're typing this into somebody's chart. You write PTU. And these are just medications that stop the thyroid from producing as much thyroid hormone. And you can adjust that dose. So, depending on how hyper, to the degree
Mhm.
of hyperthyroidism that they have, you can give them a higher dose. And then as their levels improve, you can start to reduce that down. We do have to watch things like their liver function and their white blood cell count when they're on these medications. So, we do a lot of safety labs at the same time.
Mhm. And then when I was doing my clinical practicums with you all, I heard radioactive iodine as an option, but then we said no one does radioactive iodine anymore. So tell me more about that. Why don't we do that for Graves' disease as much?
Yeah. I mean, we still can. The problem
Yeah.
with that is that if you give someone radioactive iodine when their Graves' antibodies are really high in their system,
Mm-hmm.
you can actually precipitate and worsen thyroid-related eye disease. And
Mm-hmm.
it doesn't necessarily have to be at the time that they
Mm-hmm.
get the radioactive iodine that they get thyroid-related eye disease. I have seen patients now that have come to see me decades later after they have radioactive iodine in another state, decades before, and they come to see me and now they've gotten thyroid related eye disease. I don't know what their Graves antibodies were at that time, but I have to assume they were high because we do know that the higher the antibodies are at the time you receive reactive iodine, the more likely you will be to precipitate thyroid-related eye disease at some point in your life.
Mm-hmm.
So because of that, we tend not to really choose reactive iodine immediately. If I have someone I'm very worried about, I will calm them down with anti-thyroid drug, and then we could take out their thyroid
Mm-hmm.
Not that I would never give radioactive iodine. I just think it's kind of the decision of least viability. Like I just don't prefer it.
Well,
Mm-hmm.
and I also think some of the newer data that's come out about solid organ cancers from
Hmm.
radiation.
Yeah,
Mm-hmm.
So
Mm-hmm.
we
yeah.
things like breast cancer, for example,
Mm-hmm.
Hmm.
we have seen some increased risk
Yeah.
anytime you expose somebody because it radioactive iodine is a
Hmm.
form of radiation. And
Mm-hmm.
Yeah.
so we've seen, if I have an 80-year-old who
Right.
I don't, I don't have a life expectancy much beyond
For
10,
40 more
20,
years.
30
Yeah.
years, then that person,
That
I'm less concerned about a solid organ cancer in the next 20, 30 years
right. So you
versus
might
if I
give
have a
them radioactive
30-year-old,
iodine. Yeah.
that's very
Mm-hmm.
different.
Mm-hmm.
Yeah. I agree with you on that. Yeah.
Absolutely. So, treatment really is individualized, just depending
Hmm.
on what your symptoms are, what your situation is, if you're pregnant, if you're not pregnant.
Hmm.
So we consider all of those things before we prescribe something. And surgery is the definitive treatment for Graves' disease.
Hmm.
So we talk to our patients about that as well.
Yeah. And I
Hmm.
do just want to mention right now that there are some really exciting research studies that are going on looking at medications that will essentially block the antibodies. So
Mhm.
instead of just treating the overproduction of the Graves' disease, but actually block the process. And I am very hopeful that that's something that will be available in 2 to 3 years. I do like, I'm very excited about this. It's been used to treat thyroid-related eye disease, but why not use this to treat autoimmune thyroid disease that is not eye disease or hypothyroidism or hyperthyroidism that is not associated with thyroid-related eye disease.
Hmm.
Mhm.
Yeah,
Yeah.
and I might have misspoke. I don't know exactly when methimazole first came out. I feel like it was 1950s, but it was a long time ago. And the fact that we still we're just now figuring out, oh, maybe instead of putting a Band-Aid on it, we could actually treat the underlying
Yeah.
cause is an interesting
Oh,
and
yeah.
novel approach now.
Yeah.
Hmm.
We have
Yeah,
some,
for
we have,
most autoimmune diseases, we try to calm down the immune system and
Correct.
really
mhm,
treat that, but
yeah.
not
Yeah.
with thyroid disease. We're a little bit
Hmm.
behind.
Yeah.
Let's just
Yeah.
keep our fingers crossed that we can continue our research.
Yes.
Hmm.
Yeah.
Yeah.
We have funding for that. I will put in one more point about
Okay.
surgery. If
Hmm.
someone decides, maybe they don't tolerate the medication,
Hmm.
maybe it's been years and that it's not getting better. It's really important to have a quality endocrine trained surgeon that takes your
Yes.
thyroid out.
Yes. Yes.
Hmm. That is
Yes.
very important.
Turns out your thyroid is right there where your voice box is, where you
Mhm.
talk,
Yep. Yep.
Hmm.
where you get your airway. It's
Mhm.
it's it's in a place that where you have a lot of things that you appreciate
Yeah.
having, and
Yeah.
if things go awry, um,
It could be worth traveling to a city who has an endocrine trained surgeon, is what
correct.
we're saying. Yeah.
Yeah.
Yes.
Okay, perfect.
All
Okay.
right.
Do we have any other thing that we're talking about?
Yeah, no, we're talking about our hormone hotline.
Oh,
Hmm.
shoot. Okay.
Right?
Okay, hold on.
Okay. So Christina from Los Angeles.
It's the phone ringing. The phone's ringing.
Oh, I'm sorry. But Christina already called me.
Okay, okay, I'm done.
All right, Christina from Los Angeles. I'd like to submit a hormone hotline question. Most recently, I got labs and my TSH is still out of the normal range, but my T4 is normal. Doctor recommends just monitoring for now. How can I make sense of my labs? My TSH is zero point 0.3. Normal is between like zero point 0.5 and 4. So TSH is zero point 0.3.
Do we know how old she is? Did she
Uh,
say?
she didn't
I do.
say,
She's
yeah.
32.
Okay,
She's
she's
one of my
32.
friends.
Oh, okay.
Oh,
All
your
right.
friend
Okay.
sent this message. Okay.
Uh-huh.
Oh, so nice. Okay.
I just have a
So,
lot of questions for her.
Okay,
yeah,
ask
me
me. Maybe I
too.
can provide the answers.
Okay. All right. I want to know first if she's on supplements, biotin or collagen that can make that TSH artificially low and
She is
not be a
not.
real low. Okay, so it
Okay,
is
she's
really
not.
low.
Hmm.
Okay.
And does she have symptoms?
She is not symptomatic. No, no symptoms of
No symptoms.
hyperthyroidism. Hmm.
Okay, and then any history of thyroid dysfunction herself,
No,
not on thyroid hormone.
not on thyroid hormone. No, and no known family history of thyroid.
Okay.
Okay.
Hmm.
Okay.
And does she have a family history of thyroid disease?
That's what
No
she just said.
family
None.
history of
Or no?
thyroid
And
disease.
no autoimmune diseases in the family.
No autoimmune diseases in the
Okay.
family, no autoimmune diseases herself.
Okay,
Do we
why does
have,
she care about this TSH of 0.3?
Yeah, why
because
do
it
we
said it was
care about
normal.
it?
She said it was abnormal. And she's like, I don't want to be red on my labs.
Yeah,
Okay.
why
Do
is
we
it
have like serial,
red?
do we have serial TSHs on her? Like, do we know where her TSHs have been over the
Uh-huh.
years?
Yeah, so they've always well, not always, but since she has had kept records, they've been on the low end. So 0.34, 0.27, but mainly hanging in the 0.3s for the last 4 years.
Have they ever checked a T3 level? Has it just been T4?
It's just been T4. A T3 level hasn't been
I
checked.
want a T3. The reason I want a T3 is that T3 will be elevated in a toxic nodule and some mild subclinical Graves' disease, but the T4 will be normal.
Mm-hmm.
Hmm.
And I'd probably check all of her antibodies.
I would too. And I would also get an ultrasound to see if she has a nodule in there that could be overproducing thyroid hormone.
Mm-hmm.
So
Because
all
some of
good
these
things.
little, when you're 30 something and you got just like a mildly oversecreting
Yeah,
nodule, you oftentimes
yeah,
have no idea. You don't feel it.
Hmm.
yeah. And when you're 32, you said she's 32?
Hmm.
Like it's not going to matter, but if you have these labs till you're like 50 and you're subclinically hyperthyroid for that long, you could have extensive bone loss
Yeah.
and you could be putting stress on your heart. So we want to know what it is.
Yeah, so that was kind of my point of why do we care that this lab
Yeah,
is, red? It's because of the long term.
yeah,
Yeah.
Um,
Yeah.
yeah.
I think the other point though is that let's say let's say her T4 and her T3 are normal, her antibodies are all negative, her ultrasound shows no nodules. It's also a possibility that this is her normal.
mhm,
Because when we look at data
Mhm.
for people, we say 85% of people, zero point 0.5 to 4.5, something like that. But that other 10 to 15% might
mhm.
be slightly outside of those normals, and that may
Yeah,
be normal for them.
yeah.
So knowing those sort kind of serial consistent
Right.
TSHs, if they've been
That's
like that, and
helpful.
we've ruled out all the other stuff, that might just
Yeah,
be her.
normal. Yeah.
Which means a free T3, a neck ultrasound.
Hmm.
Mm-hmm.
And I sometimes will have them like do different labs too. I'll compare like Quest versus LabCorp
Yeah,
because
Yes.
I want to know.
exactly.
Hmm.
Mm-hmm. Because certain
All right.
labs have better assays than others.
All right,
Y'all are
Christina,
some
you have your
smart,
homework.
y'all are some
Okay, let
smart
us know,
ladies there.
Christina.
Yeah.
All right, see y'all next time. Thanks for tuning in to Endocrine Uncovered. Follow us on Instagram at endo.uncovered for tips, updates, and behind the scenes content. Have a question to submit? Email us at askhormonehotline@gmail.com. Don't forget to like, subscribe, and leave us a comment. Listen to us wherever you get your podcasts. Until next time, stay curious and take care of your hormones. The information shared on this podcast is for educational purposes only. Always talk to your doctor or healthcare provider about your individual health needs.